was a great introduction, John. Thanks for allowing me to participate in this. I'll try not to use the word suck too much, but as you get older, you kind of lose your filters a little bit. So anyway, we're all used to pulling out the mini C-arm and looking at the bones. To me, the ultrasound machine is exactly the same thing, except for now I can see the tendons, ligaments, nerves, masses. And it's really easy to do. I started with the hospital one, of course, on the cart, but I also bought a butterfly. And now I've graduated to the Clarius, which is 20 megahertz. And I think the ultrasound, the hand surgeon of the future is we're all going to have one. I mean, they're going to sell them in popcorn boxes, for goodness sake. And they're so useful. So even for something simple like finding wood, so solid is white, and then the black stuff around it, that's water. And it's really easy to see these things. Think of your probe like a credit card, because that's all you're seeing. You're seeing the width of a credit card. And so it's like you're seeing a CT slice. And so you got to move it around. Just like when you're looking at a CT, you go up and down and you look at all the slices and you keep your probe moving till you see what you need to see. Always start by finding the bone because, hey, we can all find the bone. And then you ask the patient to move the tendons. And then you go, oh, okay, there's the tendon. And then you know everything else because you know your anatomy. And if you're moving the probe all the time, then you're able to see a lot more. So move it proximal to distal, radial to ulnar, tilt it up and down, rotate it 180 degrees, and things will come into view. You'll get it. If you look at a still picture, this is a still picture of a motor branch of the median nerve. Sure it is. Like, forget it. There's no way you can do it. But if you got the probe and you're following the median nerve, then you can follow this thing like a movie. And all of a sudden it becomes terrific. So still shots are useless. And that's what turns a lot of people off because they see in journals this, 80 shades of gray and they go, oh my God. This is Gonzalo Belmar de Chile, and he's an ultrasonographer, radiologist. If you're on LinkedIn, look at his videos. They're amazing. So this is a longitudinal view lengthwise, and this is adductor pollicis. And again, nothing's happening, but when you start moving, you go, oh, okay, there's the intertendinous septum right in between APL and APB into Corvinus canal. Isn't that cool? And then you turn the probe around so that you can see it on a transverse view or a short axis view. And there's abductor pollicis longus, extensor pollicis brevis, and the intertendinous septum. And this is just moving your probe up and down the forearm. So you've got to keep that probe moving if you want to see what's going on. So in flexor tendons, you want a short incision so that you have less scarring and less risk of tenolysis. So this was a 1-month-old FDP of the ring and small. There she is pre-op and post-op result. And there I am with my Clarius in my office where I did the surgery. And you find the bone first, and look over the bone. There's this big empty space there where there's usually tendons. That's a sign. There's no tendon there. And so you follow down the middle phalanx, and you get to the PIP joint, and even though it's a month old, you ask the patient to flex, and lo and behold, you see the tendon move. So you know profundus is there, you see superficialis is there. I don't need to make a long incision. I can make a short incision, fewer adhesions, less scarring. And it's really easy to do this stuff. So this is where it's very helpful. The patient gets stuck after surgery. They come in, and you don't know if the tendon's cut or not. It's not cut. You can see it there. You can even see the fiber wire in the tendon over the middle phalanx. And so you go, okay, I don't need to do a tenolysis on this guy. In fact, here's what I'm going to do. I'm going to hand the patient the ultrasound probe. Oh, it's really hard to learn. You teach patients to do this stuff. And see your tendon? It is moving. Yeah, that's a good thing to do, guy. And so here's a typical case. We all have this. So I repair this profundus tendon, long finger, nice, long, skinny finger. Should get a good result, right? But, and at 4 days, he does. At 4 days, he's moving beautifully. At 2 weeks, profundus is moving beautifully. Just watch his long finger profundus move there. Isn't that nice? But then the therapist calls me at 4 weeks and says, "Done, it ain't moving, maybe it's ruptured." No, it's not. There's the ultrasound, says it's just fine. So we put him in a relative motion extension splint, and 1 week after, you can see his profundus is starting to move. So they exercise while they're living in these splints. So quick ultrasound diagnosis in the clinic. Here he is 4 weeks after the relative motion extension splint, and you can see profundus is moving nicely. And he ended up with a total full range of motion. So here's a 3-month-old FPL laceration. So where's the proximal end? Now, when I was a younger surgeon, I used to make a separate incision in the wrist, not anymore, because most of the time it's sitting right at the middle of the metacarpal. And when you ask the patient to flex, you see the stump move. And then when you take them to surgery, that's the spot where I saw the proximal end of the tendon, and sure enough, that's exactly where it was when I did his surgery. And so it's very helpful for finding tendons. We published this paper this year, and it's open access. If you just look up ultrasound Lalonde flexor tendon, there's a bunch of videos in there on how to teach yourself. It's for free. So another film on UCL injuries. So there's the normal UCL, and see the adductor aponeurosis sliding there because you ask the patient to move, or you move the IP joint, and you're looking for the adductor tubercle right there. That's where the ligament starts off on the MP joint. Now, the orange arrow is showing where the ligament's ruptured, but inside the capsule. You don't have to operate on these. It's not a Stenner's lesion. And you go, "Oh, great, have a cast, have a nice day." And these people are just fine. But when the ligament is completely torn, it comes out of the adductor aponeurosis for a true Stenner's lesion with a complete UCL rupture. And so there's the proximal end of the ligament off the adductor tubercle, and it's outside the adductor aponeurosis. And you go, "Oh, yeah, okay, but watch it move." And then you see the adductor aponeurosis move, and you go, "Okay, all right, I'm getting this." And in some views you see it, and some you don't. It's like a CT scan. You know, some views you see the tumor, other views you don't. You just keep moving till you see everything. And there's the ligament outside adductor aponeurosis. So off you go and operate on it. Right, so here's one of my own cases. In blue is the adductor aponeurosis. In yellow is the ligament. Still picture, really, Don? Sure it is. But if you move it and you see everything moving around, you see the water around the ligament where there's inflammation. Water's black always. Right. So this was a case where my partner said, "This guy's sore as hell and he doesn't even want me to examine him." And I said, "That's okay, we'll dunk him in a bowl of water," because water magnifies the ultrasound waves. It turns a low frequency into a high frequency probe. And so you put goop in the glove, put the glove in the water, and now you're not even touching the wound. So you can take acute hand injuries. You can easily see that his extensor tendon is intact, and so he doesn't need an operation. Have a nice day. You got to keep that probe moving until you get a glimpse of an important view, and then pause. Still photos are worth 1,000 words. Movies are worth 1,000 photos. So make your exam a movie. I know I'm repeating myself a little bit, but it's kind of important. So when you're putting a needle in something, you see the needles coming in there, and you're going to see multiple shadows. See all little shadows off of that thing? That's when you know you're in, and then you aspirate the ganglion. One trick that I learned is how to explode flexor sheath ganglions, but it's a lot easier to do that now that I have ultrasound. And so you can actually cure flexor sheath ganglions this way. And what you do is you put your needle inside the ganglion cyst. They're pretty small sometimes. So if you're guessing at these, like I used to before getting the ultrasound. So now, okay, there I go. There's my needle. You can just barely see it. It's coming into view. And once it's in view, I simply explode the flexor sheath ganglion with some local and have a nice day. Black is water. And keep those fingers together so you don't lose your gel. So this is what ganglions look like. One of the questions was, how do you tell a ganglion? It's black because it's all water. You know, white is bone. The more solid it is, the whiter it is. So this is a glomus tumor. And this is what it looks like when I take it out, and this is what it looks like in the patient. It's gray. It's not black. So I'm looking at this and I'm going, wait a minute, that's not a ganglion. What the hell is that? And it was a glomus tumor. And white, again, is solid. Now, lipomas are pretty much homogeneous. This wasn't homogeneous. This was kind of weird. That's weird right there. That's what weird looks like. And so this is a benign angioleiomyoma. And if you've got a very thick layer of gel, it helps. This is a post-traumatic vascular malformation. It's tender to touch. And this happened when she smacked it. So an arteriole heals to a venule, and then you get a direct AV communication, which is slowly expanding. And when you look in just a second here, when you turn on the Doppler, there it is. There's the arteriole going into the vascular malformation. It's red. And so at surgery, which I do with Wallant, of course, is there any other way to operate? But I do use a tourniquet with vascular malformations. I use a very expensive one. I cut the tip off a glove and roll it down. And then I take out the vascular malformation. And you're going to see the little arteriole that I saw on ultrasound, and there it is right there. And as long as you cut that sucker, it's not going to feed into the veins anymore, and Bob's your uncle. So when you're doing Dupuytren's, it's really nice to know that your artery is wrapped, and more importantly, your nerve is wrapped around the cord. So that artery is going north instead of sideways. What the hell's that? That's a spiral cord. Nice to know, huh? Takes 2 seconds. So use the probe like you're examining finger. You know how you press on something and you go, does that hurt? Well, press with the probe and go, hey, does that hurt? And turn your probe around so your probe is kind of like a finger, except for the difference is you can see what's under your finger. It's very clever that way. And try that. Right, so there's pus where that square is. Sure there is. Dawn, come on. So that square is just above the forearm fascia, and above that is fat, right? So you can't see anything. But if you press on it, look at the liquid going up and down the fascia. Oh, dear, there's pus in there. So you can put a needle in it, or you can follow it along and see where the pus pocket ends. Oh, it ends there. That's kind of nice to know before surgery. Sorry, the slides are just having a little bit of a hard time. So this is over the shoulder. This was a lipoma over the trapezius. Trapezius at the bottom, and when I ask him to move his muscles, I can see it move. The lipoma's on top. Remember I said it was more kind of homogeneous? That's what lipomas look like. But I don't want to hurt the 11th nerve, and now I know the lipoma's over the trapezius and not under it. So that's helpful to know before surgery, isn't it? So this is from Vincent Martinel, who's a French hand surgeon. He's brilliant. You know, in France, the only way they can do office surgery is with ultrasound because they're not making an incision. But they can do ultrasound-guided surgery in the office. So this is on the left without a booster, and on the right with a booster. And why is it that you can see the ganglion move up and down so well? Because there's that thick layer of gel between the probe and the skin. So how do you keep that thick layer of gel between the probe and the skin? With a booster. So how do you make a booster? They're very expensive. You take paper tapes that come on your ultrasound probe cover or on microscope covers or on surgical gowns, you know, the tape things. And you take one of those tape things, instead of throwing it away, you take off the non-sticky side, you put the sticky side on your ultrasound probe, and you wrap it around, and voila, you have a little cup in which to put your thickest ultrasound gel possible, like mayonnaise. And when you put it in, you can turn your probe upside down and it doesn't go anywhere. So you can examine the surface of the extensor tendon of the finger, and you don't get all the black artifact of air. So this is Vincent Martinel's idea. The left without a booster, the right with a booster. And this is tenosynovitis. And see all the gel between the skin and the probe? And look at, as you come up the finger, and even the distal phalanx, you're never seen a distal phalanx so nicely as when you have a lot of gel between the skin and the probe. So the key is gel between the skin and the probe. Here's my own central slip with my Clarius L20, but I got a lot of gel there. But you see the central slip on my PIP joint? Look at that, right as rain, man. It's hard to miss once you know what you're looking at. So this is a case of Vincent Martinez. It's 2 months after PIP injury. And you want to know if the central slip is still intact or not. So on the left is without a booster, on the right is with a booster. And with a booster, the gel stays on the finger, so there's no artifacts. And even when you flex the PIP joint, you can see that the central slip is intact. And if you're going around a finger, a booster keeps the gel on the finger. You can't go around the finger. I mean, the gel's going to fall off if you don't have something to keep it there. So the key is you want a mountain of gel. So this is a schwannoma of the median nerve. This is a transverse view. There's the median nerve right there. And if you go up and down the forearm like a movie, there's the schwannoma right there, the big black thing. And then we're going to look at it in the longitudinal view or the long axis. And without a booster, you can see it, but with a booster, you can see it so much better. Oh my God, it's like, wow, that's really good. In fact, it might even be better than the MRI. I don't know. Anyway, it's a lot easier to get. So make a mountain of gel and glide your probe at the top of the mountain. And when you're examining fingers, hold the fingers together to maintain the gel mountain. And sometimes consider using your non-examining hand to guide your probe, like your thumb and your long finger, so that your probe stays in the valley of your thumb and long finger, so it doesn't fall off the finger. It can be a two-handed sport. I love that at the handout they say, rest your hand, because you don't want to squish the gel out. You want to keep the gel, either on top of a mountain or with a booster. And there's the view when you press on the skin. All right. Ultrasound-guided surgery, I think everybody should do it, really. I'm going to be 71 in 2 weeks, so I'm not going to start now. And you still can't get the ultrasound knives in Canada. I think all surgeons should get into it. The reason the French are so good is it's the only way they can do surgery in their office. And it just makes sense. You know, you can see more with that than you can with an endoscope, because you can see all the stuff above and below the ligament, and you can see if the median nerve is bifid or not, and all these things. So yes, I think we should all get into it. So how do you teach yourself? It was a question that people were asking. Well, most patients come in with 2 hands. So you look at the normal hand first, and then you look at the hand with a pathology, and then teach yourself, because you know your anatomy, you know your pathology. And you're going to be going in to look at it, so you're going to figure out if what you thought was right or not. So it's best to teach yourself. And also in the second edition of the Wide Awake Hand Surgery book, Brian Gerbal is a great teacher. He taught me 8 hours of video on how to teach yourself ultrasound, how to use the probe, how to do surgery with ultrasound. And I think it's worth considering. There we go. That's it. Thank you.